Now I'd like to invite Dr. Rehman. He is from Shroff Eye Institute. He will be speaking on IgG4 related disease, and he had a few publications on this IgG4 related disease. Dr. Ubaid.
So good morning, everyone. I'm going to start by thanking Dipankar Das sir, who's been a great mentor to me, and I'm very grateful to be in this instruction course amongst the great minds in ophthalmology. So my topic for today is clinical pathology of IgG4 related disease, and to look at what is the IgG4 antibody. So IgG is the most common antibody in the body, and it has 4 subclasses 1, 2, 3 and 4. And out of all those 4 subclasses, IgG4 is actually the least common subtype of IgG antibody, and it has been linked with chronic exposure to antigens, and it has also been observed in allergic conditions, helminthic infections in conjunction with IgE antibody. So IgG4 related disorders are a diverse group of inflammatory disorders that are characterized by influx of IgG4 positive cells in the affected tissues, high serum level of IgG4, and they can affect multiple organs. And IgG4 related ophthalmic disorder is when this IgG related disorder affects the orbital or the ocular tissues. So we'll be looking at 2 cases. This is case number 1. This was a 66-year-old male who presented to the oculoplasty clinic with painless and progressive swelling in his eyelids for the past 6 months. On further systemic examination, we saw there were enlarged submandibular glands, which can be seen here in the photo, and these masses had a very firm rubbery consistency. On evaluation, even his parotid glands were enlarged, and the consistency of all the 3 types of swellings were similar. So we advised imaging to this patient, and the patient returned with a CT scan of the orbits. On the CT scan, you can see there's a homogeneous hypodense lesions in both the orbits in the lacrimal gland region supratemporally. And if we look at the axial scan, you'll see there's a spillover of these lesion into the eyelids. So there is eyelid swelling also, preseptal swelling, and going up to the nasal side from the temporal side. So in our mind, we kept diagnosis of lacrimal gland lymphoma, Mikulicz syndrome, and Sjogren syndrome. And lacrimal gland lymphoma can be bilateral also. However, this patient did not have any reduced Schirmer's and no dry eye symptoms. So an incision biopsy was performed from the left lacrimal gland, and histopathology was studied. On seeing the histopathological slides, there was a very rich lymphoplasmacytic infiltrate, and germinal center formation was also noted. So following histopathology, immunohistochemistry strains were done. This patient was positive for CD20 and CD3, so both pan B cell and pan T cell markers. Then he was positive for CD138, that is for plasma cells, and his positivity for IgG4 positive cells was more than 50 per high power field, and there was polyclonality in the form of lambda and kappa positivity. So blood testing was also performed for this patient by a rheumatologist, in which serum IgG4 levels were highly raised, but other autoimmune profile was totally normal for this patient. So a diagnosis of IgG4 related orbital disease was formed, and the patient was started on a tapering dose of oral steroids along with mycophenolate mofetil. Unfortunately, I don't have the follow-up pictures of this patient, since this patient was from outstation, but a close follow-up was maintained over video consultation, and reduction in all the swellings was noted. Case number 2 is a young female who presented to the uveitis clinic actually with diminution of vision, pain and redness for past 6 months. Her visual acuity in the right eye was counting finger close to face, and there was a lot of congestion and redness as can be seen. On evaluation of the anterior segment, there were 360 degrees posterior synecdoche formation and hypopyon. And on close observation, there was an iris bulge in the inferior region, confusing us with a retroiris mass. So an ultrasound B scan was done for this patient. A mass lesion in the ciliary body region was noted. following which the patient was advised for MRI orbits, and even in the MRI orbits it was confirmed that there is a ciliary body mass. So we kept two diagnoses in mind, the first one being a ciliary body melanoma and a second one of medulloepithelioma. The patient was counseled for right eye enucleation, and following enucleation, on grossing of the specimen, a white tan grayish mass was seen in the ciliary body region, which can be seen this. Okay, there is no pointer, but in the ciliary body region there is a whitish grayish mass, and just behind that is a retinal detachment. So on histopathology, again a very rich lymphoplasmacytic infiltrate was noted in this patient, and the immunohistochemistry was similar to the first patient, and IgG4 positive cells were again exceeding more than 50 per high power field. On her autoimmune profile and blood workup, serum IgG4 levels were highly raised. This was the only abnormal blood workup noted. All the other blood workup was normal. So IgG4 related disease is a relatively newer disease which was described in 2001 in Japan, and it's a fibroinflammatory disease with formation of mass lesions with IgG4 positive plasma cell infiltration. Although a median age of 58 to 67 years has been noted, but it can also affect a younger age group. And IgG4 related disease is more common in males, but when we look at IgG4 related ophthalmic disease, it has a similar predilection for males and females, and it can involve multiple organs and lead to autoimmune pancreatitis. There is ophthalmic involvement, there can be sclerosing cholangitis, lymph node masses, autoimmune nephritis, and even retroperitoneal fibrosis. The most common systemic organ affected is the pancreas, followed by the orbital lesions, and most common ophthalmic part affected is the lacrimal gland. So lacrimal gland is overall the second most common organ affected, and if we look at the different sites where it can affect from the lacrimal sac to the lacrimal gland, cases have been described in the sclera, in the uvea, in the optic nerve sheath, orbital apex, in the fat tissue of the eye, and even in the extraocular muscles. But 69% of IgG4 related ophthalmic disease will involve the lacrimal gland, and out of those 48% will be bilaterally affected. So the pathogenesis of this disease is very poorly understood. Majority of patients have associated allergic conditions, and there may be a correlation with that. There may be a modified Th2 response. So there have been various hypotheses that have been put up. One of them is role of molecular mimicry with infection of H. pylori and E. coli, which might lead to autoantibody formation in this disease. So clinically, the patient usually present to us with an insidious onset of mass lesions with a relapsing and recurring course. And in the eye, mostly lacrimal gland, as I mentioned before, is affected, followed by the various soft tissues in and around the eye, the extraocular muscles, optic nerve, and even there can be nerve infiltration of the trigeminal nerve, of the infraorbital and the supraorbital nerves. So usually, since lacrimal gland is the most commonly affected organ, patients will commonly present with a painless proptosis, associated eyelid swelling, and if there is a posterior lesion, then maybe reduced vision. Then atypical cases that have been described in literature have included uveitis, uveal mass, which was seen in our second patient, scleritis, and even conjunctivitis. And out of these patients who have ophthalmic disease, 75 to 100 patients will also have extraocular manifestations. So a systemic examination is very crucial in these patients. So in imaging, CT or MRI will show bilateral symmetrical diffuse enlargement of the lacrimal glands, and depending on the site, there can be soft tissue thickening in various organs. Then MRI can also show enlarged supraorbital and infraorbital nerves, and sometimes these nerves may even become thicker than the optic nerve on imaging. Then PET CT scan is another important scan that can be done in this patient, because it can pick up involvement of all the other organs by showing high uptake of FDG, and which might not be picked up by conventional clinical examination. So PET CT can actually guide us in maintaining therapy of the patient and if any intervention is required. On histopathology, as was seen in our two patients, there will be a dense lymphoplasmacytic infiltrate. There can be germinal center formation. And obliterative phlebitis, although common in systemic IgG4, is pretty uncommon in ophthalmic IgG4. And IgG4 positive plasma cells will be seen. So these are the diagnostic criteria that have been given by the Japanese study group for diagnosis of IgG4 related ophthalmic disease. Number one, showing enlarged lacrimal glands or the affected organ, which was seen in both our patients, although the gold standard always is histopathology. And IgG4 positive plasma cells are usually more than 50 per high power field for ophthalmic disorder, but for the systemic disorder, this count is more than 10 per high power field. IgG4 to IgG4 plus ratio more than 40%, and raised serum IgG4 levels, although in 30 to 40% patients these may be normal. There is another study by the American College of Rheumatology that came out in 2009, and they gave a three-step criteria for diagnosing IgG4. In the first step, there should be involvement of at least 1 out of 11 described organs. Then the second step is very cumbersome. So you have to look at 32 exclusion criteria that involves clinical, serological, pathological criteria. And then after exclusion of these 32 criteria, there's a third step in which you have to look at 8 different domains. Again, they have imaging, clinical, microbiological, pathological, a lot of criteria. So it's a very cumbersome classification and not usually followed, but a total score of 20 in this classification can carry a specificity of more than 99% in diagnosing IgG4. So important differential diagnosis that should be kept in mind whenever dealing with IgG4 disease. The first one is idiopathic inflammatory disease, but it's going to differ from IgG4 in having symptoms of sudden onset of pain, inflammation, and extraocular movement restriction, which is usually not seen in IgG4 disease. Another very important differential diagnosis is a marginal zone B-cell lymphoma, which can share certain common findings with IgG4 related ophthalmic disease, such as lymphoid cells. Even raised IgG4 levels in the serum and in the tissue can be seen. Then thyroid orbitopathy, although it will have very different set of symptoms and clinical signs, it should be kept in mind. And vasculitis is another common differential diagnosis of IgG4 related ophthalmic disorder. Again, there will be periocular pain in any vasculitis, and sarcoidosis can be another differential diagnosis. So there are no standard treatment protocols for management of IgG4 disease till now. Systemic oral steroids are usually the first line of treatment and can be started at 0.5 to 1 mg per kg. And since IgG4 has a relapsing and recurring course, the tapering should be slow and a low dose should be continued for a longer duration of time. Immunosuppressives form the second line of treatment. They are the steroid sparing agents and can also be used in steroid refractory cases. Then there's targeted therapy of rituximab, which is anti-CD20, so it can halt the conversion into plasma cells. Radiotherapy can be used as an adjunct to medical therapy, usually is not employed, and surgery is not preferred in this disease because of a lot of scarring. So IgG4 is a great mimicker. It can mimic inflammation, it can mimic tumor, it can mimic infection. So there should be a high clinical suspicion whenever dealing with these patients. Thank you.
Thank you, Dr. Obaid. Any questions for him? Padma?
They're refractory to treatment because of the scarring and the fibrosis. In that situations, we found that especially the orbital lesions respond to the local steroid injection. What is your opinion on that?
I don't have much experience with a local steroid infection. Usually the cases I have seen have responded well to systemic steroids. But in orbital lesion, a low dose stereotactic radiotherapy might also be helpful in conjunction with the medical therapy.
Only thing is that the IgG4 related disease is a systemic disease.
Yeah.
The pancreas can be involved, liver can be involved. So you see, serum IgG4 is increased in those situations. So particularly local therapy will not that effective, because if there is any other focus, that have to taken care by the systemic treatment out of it.
Yeah, we had a patient with systemic involvement was not there, only the orbital form was there. So in
Okay.
that particular condition, in addition to the systemic immunosuppressive therapy and low dose of systemic steroids, she responded to 2 or 3 periocular steroid injections.
Okay, then you have to follow up the patient.
Patient.
That's the main thing. Thank you, Padma. Thank you, Dr. Ubaid.
Thank you.
Yeah, JB sir, please give your comment.
See, it was in 2005, I was in Hong Kong. There is a doctor whose name is Dr. Hunter Nguyen. He published a series of cases of orbital IgG4 mediated disease, and he was one of the first to describe this. He showed me how is the IgG4 disease can present. The scleritis is another condition where you should see IgG4, you should suspect. And nowadays there is that lymphoplasmacytic infiltration where you do not find any etiology, no pattern. IgG4 mediated disease we should suspect, and the serum IgG4 should be done in such cases. So it's you have to keep a very inquisitive mind to find out the IgG4 mediated disease. They are much more than what we expect.
Thank you, sir, for this